we're going to postpone that presentation for a while. I knew that Carla has a closet full of presentations. She gives many of them throughout town. So I called her and asked her if she could pull one of those out and present today, and she agreed to do that. So we will turn the time over to Carla for her presentation.
Okay. Good afternoon, everyone. Thank you, Joyce. So as Joyce mentioned, my name is Carla Fries. I'm a Parkinson's site champion and have done extensive research and training with the Parkinson's Foundation and with UNMC. And the subject that I'm going to be presenting today is pretty much focused on medications and the importance of timing. I know we've talked a lot about this and a lot about healthcare facilities and how much we wish they knew more about it. And so as Joyce mentioned, this is one of the topics as I speak to skilled nursing facilities, rehabs, assisted livings, etc. Some of this research I present to them to try to make sure the message is loud and clear of how timed medication has consequences. So that's kind of the majority of what we're going to talk about today. If you have questions, sometimes we have no parts, but if you have questions, I was going to say jot them down, but we'll take questions at the end if that's okay. So hold your questions and try to hang on to them till the end. Sometimes I find that I cover questions in the next slides. I find that happens. So but we'll have plenty of time for questions and answers. So we're going to talk, like I said, about timed medications. And to do that, I'd like to start with the term on track and off track. When it comes to your providers, so your neurologist or your movement specialist, raise your hand if they use this term on track. Not many do, just a couple. Okay, so, and that's okay, this is a fairly new term, but a lot of this education when I'm training my team at Home Care Partners and facility teams, use this term, on track and off track. And when I try to keep things really simple, I'll say, think about a car. When your car is out of gas, what happens? What happens, Helen?
Won't start.
It won't start, it won't go. So I just will say, stop right there. If that is all you walk out with, that is the message. When our tank is on empty, we can't go. That's off track. Okay, so just kind of think about that. And I like that metaphor. And I know I've shared this before and I presented at Madonna and some of you were there for that presentation. And I kind of paused and after we did kind of icebreakers and warmed up the room. And I said, when you tell somebody you have Parkinson's and they say, what does that mean? It was kind of a hard question. It was a little bit of silence and somebody said, well, I just say I have good days and bad days. Which, yeah, not right or wrong, but it's not that you're having a bad day, it's your tank is empty. So we're running on empty. So I like that a little better because what it does for care partners and facilities and caregivers is to tell us what my job is. If I'm supporting you or assisting you is to make sure that your tank doesn't get empty, stays on full, and we stay on track. So when you hear me talk about that, I kind of think about it as, we can only put in 1 gallon of gas at a time. So unless we put in more gas, we only can put in 1 gallon at a time. We run out. And our medication, whatever form you use, I have handouts, I'll give them at the end. I know what happens when you hand out handouts at the beginning of your presentation. So whatever form of carbidopa, levodopa you use, that's the gas. Okay, so when we talk about on track, we're taking the right medications at the right time and the right absorption. We've had speakers, Jenna, I think was the nutritionist, UNMC speaker, that talk about the protein effect. I'll touch on that. But we want right med, right time with the right absorption, wherever the med's going. Okay. And that means we're on track. We're functioning at our highest level. When we're off track, when we're out of gas, that's when we have a difficulty with everything, right? Because we all know, I skipped like my first 20 slides because we all in this room know what Parkinson's is, and we know a lot of, the side effects. But so we have difficulty moving. We're gonna have a lot more falls when we're off track. We're a lot more likely to be hospitalized. And as we all know, when we have hospitalizations, they're a lot more complicated. There's major setbacks, and we're there longer. So that's the consequence of being off track when we're out of gas. I thought this was interesting. When we went through our site champion training, we talked a little bit about the different stages of Parkinson's, but then in one day, depending on somebody, if somebody's on track or off track, that you could fluctuate in and out of these stages in one day. I thought, wow, that's really interesting, because it's not that we're at a certain stage always. Really depends if our meds are working and we're on track. And when we're not, we can go to a stage 5 pretty quickly. So like I said, I'm not going to get into all the different medication forms. I know all of you in the room here are experts on this. But when I do present to facilities and to caregivers, again, my team's all gone through Parkinson's Site Champion training. They need to know there's a few different types and ways that we fuel our tank. And it's not just the carbidopa-levodopa, is it? There's more meds that we all take. So, for them to know, yes, somebody that has Parkinson's has a more advanced med list, but it's not just your carbidopa-levodopa. There's a variety of different things that we take. And again, there's some times on here. When we have timed medications, we are a very different patient, if we're a patient, whatever setting we're in, than others, because they may have medications, but they're not necessarily a specific time they need to be taken, whereas ours are. Now, when it comes to time medication lists, I know this is kind of hard to read, but I will really encourage you to make sure in an electronic medical record that your provider is putting as close as possible what time you take medications. Because if you get, you're in a hospital, something like that, and they just get faxed your med list, you can see how this is pretty confusing. Carbidopa-levodopa, you're supposed to give it every 8 hours as needed for Parkinson's. Just think if you're the nurse that reads this and you're like, all right, so at what time, what time do I give it? Every 8 hours, so okay. And then the next one says give tablet by mouth 2 times a day. Doesn't say what time, just says 2 times a day. And then the next one says give 1 tablet by mouth 2 times a day for Parkinson's. And then we've got another one that's for Lewy body dementia. If they're having it, that you're going to give that by mouth. So you can see here when things are in an electronic record. So part of this is education, and a large part is us knowing what time we take our meds, but also really encourage you when you are your provider or whoever your prescribing physician, we'll say that, prescribing physician is, to put that in your record, what time you take your medication. Because when this is faxed, as you can see here, it's really not clear when this hospital facility or whatever facility is supposed to give you what. I will pass these out, but our team does a great job of helping our Parkinson's families do some journaling, do some tracking, so we can try to understand better when we run out of gas. Because for a lot of us, depending on your prescriber, maybe they gave you a certain time, but maybe they just said, try every 4 hours and see how it works. Try 6 hours, try 8 hours, come back, let me know. And so it was a little bit of a guessing. How many of you was a little bit of a guessing game at first? A lot of people. Yeah. And so, trying to figure out, well, how long does this gas last? And when do I need to refuel? So that's part of when we do journaling, what we're trying to do is try to identify when somebody's on track and when they're off track. Okay, I'm going to get to a little bit of research. So I'm going to tell you about a study. This was a pretty big study. And I think everybody in this room is going to resonate with this study. But like I said, when I'm presenting to healthcare facilities, it's really important for me to present hardcore data to really get my point across. So this is 500 patients. That's a lot of people with Parkinson's. And the average age was 77. So I think it's pretty representative of our room here, right? Everybody, close, right? This is a mean. I realize there's younger people and there's older people, but that's the average, right? So a big study. Of this study, 212 of those almost 500 patients were off track during the stay. 43% have a levodopa equivalent daily dose deviation. That deviation is 30 minutes. So they had to wait more than 30 minutes than when they were supposed to get their med. So 43%. 19% had a substitution. They were given a medication that didn't even match up to whatever they were supposed to have. Okay, so now let's dive into a few consequences. The length of stay for all of these families that were off track, had these off track experiences because they didn't get their meds on time, was 7.6 days versus 3.8 for those people that did get their meds on time. They say every day in the hospital is a week of recovery. So look at the setback that this individual didn't get their meds on time. This is major setback. You can see here, it's not a huge deal to, not as big of a deal to overdose, only 4% of an impact there. But when we had an underdose, we had a 14% longer stay. When somebody missed a dose, we think about when we miss a dose. So if you're hypothetically, you take your med 8, 12, and then again at dinner time, if we miss that 12 o'clock time, you are out of gas, you are off track from probably 11 a.m., probably start running out of gas until you got it at dinner time, 5 or 6 p.m. That's a lot of hours and a very high risk time for someone to fall and have complications. So we'll see that here in a second. The unplanned readmissions, so that word readmission speaks pretty loudly to my hospital partners and my rehab partners. So I really hit on this because they don't want a readmission. It's not good for you for quality of life, which is our goal, right? Great outcome. But it's also not good for them because of reimbursement status. Not good for anybody. Unplanned readmission within 30 days, 91. Almost 100 people out of those 500 families were back in the hospital in less than 30 days because they didn't get their med on time. And how many days did they have at home? About a week. Yeah. Death within 90 days of discharge, 72 of these families passed away. And that average was 36 days. So they passed away. They had about a month and passed away. 18 patients passed away out of the hospital without a readmission. So some major consequences here. Discharge results. I love this result because I own a home care agency and we love helping people stay at home if that's where they want to be. 400 of these families were able to go back home to a home setting, which is great. So it's not that it's not possible. It's very possible. We need to stay on track during our recovery, whatever it is you're recovering from. And when you get home, we need to continue to stay on track. So when we think about on-off track, we talked about the timing of medications. I know many of you already do this where you set alarms, which is very helpful. Some have spouses that help you remember, some have care partners. We do a lot of medication management. And when we think about timing, again, when I visit with facilities and rehabs, you know, this may be the first time when I present to them that they are hearing this information and they are super surprised, shocked, have no idea, and then they kind of go back and change their processes. So I think about mornings and let them know the first thing we need to do is have our med. So if a med aide or a caregiver or care partner or you yourself is taking your medication, you maybe have your med that you need right by your bed with a bottle of water. The first thing you're going to do is take your med because your tank is what? It's empty. Absolutely, it's empty when you wake up in the morning. So we can't expect your car to go because you're waking up on empty. So we take our med. So I tell these med aides, you know, give them medication, come back in 30 minutes. You know, if you want someone to get up, get going, get dressed, do a bath, whatever it is, because we need 30 minutes from the time we swallow, our stomach, that's absorbed to the blood, gets back past the blood-brain barrier. So about 30 minutes for that gas to kick in is what we need. If not, you know, I let facilities know, you may be looking at what they call a 2 assist. It may take 2 people. And healthcare facilities are very understaffed. They really don't have the staff to do that, to do a 2 assist. So when they hear this, that it can be done better, it's kind of an aha moment. They're like, oh, you know, well, so-and-so will be able to move a little better if I provide this med, and then I wait 30 minutes, then maybe he or she isn't a 2 assist because their body will be working. But it does require extra patience. And then I let that individual took their medication, that's your opportune time. You're going to have the best therapy session. So for them to be very intentional about when they're scheduling appointments. And then intentional planning, ADL stands for activities of daily living. So when I speak on that note, we talk about bath aids, because it's a high risk for someone to fall when they're taking a shower if they are off track. Protein effect, I mentioned this earlier, but you know, I let facilities know that, you know, we kind of look, I think it was Dr. Situ, I forget now who said this metaphor, but it was like, there's a race, there's 2 race cars, and one's protein, and one's your carbidopa levodopa, that your protein car will win every time. And it'll be as if you didn't even take your medicine. So, you know, that's why we want to wait about 30 minutes or so for the protein, the protein. And I tell facilities this, which is so important, and I won't mention which one, but one that I spoke to recently said, gosh, you know, we've been giving these protein ensure shakes when we give the carbidopa levodopa. Stop doing that. So, you know, coffee with some creamer, you know, or something, and then wait 30 minutes and then the protein, because otherwise it's not going to have absorption. So the on track is right med, right time with proper absorption. And then letting them know too, those med aides or care partners or spouses or you yourselves, that when you do take your carbidopa levodopa, it's highly acidic. So you really want to make sure that you drink a glass of water after you take your medicine, because if that acid sits on your teeth, it's going to lead to dental problems. So that's really important. And so you always, if you can, brush your teeth after you take your meds. Pain management, over 80% of people will experience pain. And this is, most people say it's the most troubling symptom. And sometimes us not moving will cause us more pain. Our position depending on, how our spine is, if we're in a position that's just not normal, our neck or back, that can cause a lot of extra stress and strain on our skeletal system when we're in a position that our body wasn't made to be in. So then that can cause a lot of pain. So I tell my care team, we help with a lot of stretching and so forth to help with that. If we can help with posture, it may prevent pain and muscles from tensing. We're all very familiar with motor symptoms, but we're going to have more increased motor system, more shaking, bradykinesia, that's a slowing down of movement. We're going to be slower, more rigidity, and more problems walking and with our balance when we're off track. With our non-motor symptoms, thinking about cognition, that in itself is just going to be harder when we're off track too. The words won't come as easily. We won't track as easily and so forth. So things will be in general harder when we're off track for our cognition. Kind of already know a few of these already, but some of the teams that I present to, they're not as familiar with side effects. So just letting them know a couple tips and so forth. If handwriting gets smaller, maybe we can use voice to text or maybe texting. Loss of smell is a very, very early sign of Parkinson's, as we all know. And so just making sure if there are safety concerns in the house, that, we're aware of that. If there were a fire or that sort of thing, that maybe our loved one that has lost their olfactory system won't be able to smell that smoke, or maybe personal hygiene. We may not be able to smell ourselves, so our care partner or spouse, may have to gently just do reminders. Trouble sleeping is very common, as we all know. Some of I mentioned we do a lot of medication management. When we do a med reminder for something like melatonin, it's really important to go to bed or even to take that in bed, depending on your body. Sometimes that can work very quickly. And if it does work very quickly and relaxes you like it's supposed to, it's very high risk of falls if you're not going to bed. Making sure we have just good sleep environments, making sure if we can, we reduce screens and dim lights, busy days equal restful nights. Elevating someone's bed a little bit helps with that. If you're in a facility, you can ask them for uninterrupted sleep. I know that term seems fictional, doesn't it? But you can ask and see what happens. But there have been a lot of studies on uninterrupted sleep. One of my friends that did this study at Madonna, they had several people that they did this study with, and it would have been patients that didn't have pressure ulcers or skin integrity issues, right? Because that's different, and you do have to do checks and repositioning and so forth when somebody's got a pressure ulcer. But if they didn't, to uninterrupted sleep, those that slept more fell less. End of story. We're just less likely to fall. And if we could kind of cut off liquids after 7 p.m., it might help us have more of a restful night, so we're not getting up to go to the bathroom as much. And as we all know too, medication wearing off can cause our body to wake us up. So a lot of different reasons that we can't sleep as well. Difficulty moving. Again, if there are more off-track times, we want to make sure there's as much safety modifications as possible. I do a lot of home safety evaluations. So we look for, where do we need grab bars? Where do we need toilet rails? Do we have a shower bench in the shower? Things like that. Is the bed, can the bed have a bed rail? Are we using our walker or walking stick? Somebody brought that up, I think last month. And are we doing our home exercises, our one-on-one, either with your care partner or with yourself or with your caregiver, however it is. But the more we move, the more we'll continue moving. So I have these along. They look like this. This is the Parkinson's Foundation recommendation for exercises. Constipation, 80% of patients will report constipation, probably even higher than that. But some care tips, we want to stay really hydrated. You want to avoid laxatives, it's just not sustainable. And it just kind of tricks our body, and then our body's not working like it should. Add a stool softener, increase movement. And then when it comes to silent aspiration, where something goes down the wrong pipe, many people won't admit that they're aspirating, but you can see somebody coughing, right? Went down the wrong pipe and you're kind of coughing it up. That's aspiration. And so just for us, again, we do a lot of med management. I always tell our caregivers, you know, to offer one pill at a time, because even though they're small, they have that outer coating on them, right? Because they're supposed to, they have timed release. And sometimes when, you know, 3 pills are taken at the same time, those 3 pills will stick together and kind of become one big pill, which is choking hazard. So if you can, just 1 pill at a time. We've talked a little bit about aspiration already, but again, our muscles affect all different parts of our body and our systems, and swallowing is a muscle as well. Over 80% of patients have dysphagia, difficulty swallowing. So, you know, we want to make sure we're watching for that coughing and maybe report it on your journal, because it is a sign of you being off track. Unintentional weight loss. We know that in general, people that are not trying to lose weight, that are losing weight, will pass away faster. So we're not trying to lose weight, but sometimes because we're moving so much, and depending on how much, you know, tremors and that sort of thing, you're just burning a lot more calories than someone that's able to sit still. So want to make sure, if that's the case, that we're having a higher calorie diet. With the voice, again, when I'm doing some training in the community, you know, to let them know this is part of Parkinson's, that this is a muscle as well, and things will get quieter. I had one individual, and we helped him. We were caring for him something like 8 a.m. to 5 daily. And part of what he would do with the caregiver is yodel. So, you know, whatever works for you to help your voice. We've had Voice for Parkinson's, I think it's called, come and talk about speaking with intent. You'll hear that term quite a bit. But the decibel meter, my phone somewhere, but this is an app that I'll encourage my caregivers to have, and to show the individual we're caring for, so you can see what decibel, how loud you really are speaking. Because if you have Parkinson's, you will hear yourself louder than we hear you. Oh, sometimes you might find, if you're the spouse, that you're like, what? Huh? What? You know, just ask somebody to repeat themselves. We can't hear a loved one. And they're like, well, you have a hearing problem. Well, maybe I do, but also you're not speaking as loud as you think you are. So this is a way for people to see as a visual how loud they really are speaking, so that it's not my word versus your word, it is on the phone. We can look at this number and it can tell you how loud you're speaking. So that's a nice app I have our caregivers download. This is something we're probably all kind of aware of, but making sure that we don't assume somebody's feelings when we do have a masked face. So we have a lot of muscles in our face as well. So if we're not able to show the emotion, doesn't mean that people aren't feeling different feelings. You may just have to ask more questions to better understand, because we can't see it as well as we used to be able to. Dizziness, this happens quite a bit, and even more when we're off track, especially in the morning. So I talked about first thing in the morning, med. reminder. Probably the next thing is compression socks for many of the families we take care of. And that helps a lot with blood pressure. So our blood pressure is harder to recalibrate because, again, we've got another system there that pumps our blood up and down the body. And as we all know, Parkinson's really affects all of our systems. So that's something that happens quite a bit. So know your blood pressure. And then just really take more time with your transfers, especially if you're noticing it is typically it's dropping, right? And you kind of get up and you feel dizzy or lightheaded, or maybe things even go black. So, and stay hydrated. We'll have that happen a lot more when we're dehydrated. If you're worried about a fall, we talked a little bit about this. Our team uses safety devices so that in our families that we care for, if there is a fall, that we can be alerted if something's not right. There's different families that have all different resources. Kind of that old way of doing things is a life alert, which is okay. But as we all know, it does require you, 1, to wear it. First step. 2, to remember what it's for. And 3, to push the button. So if you for example, most falls happen in the bathroom. Somebody happens to fall in the bathroom, you hit your head, you're not able to push that button. So just more of a fall safe, or just a safety mechanism. So we don't want people to be afraid of falling. We know that we can fall. What we're afraid of as far as families and healthcare partners, what we're truly afraid of is not knowing that somebody fell. That's what we're really worried about. That's what keeps families up at night. So if you can have your plan of how, if something happened, how would somebody be alerted? That would be great. We don't want anybody laying on the floor. What's at risk? So we talked about being off track. So this is kind of the part where I do a little bit of a teach back and make sure that the room I just taught to, or my caregivers, that they understand, what changes are going to happen. We're more likely to fall. We're ADLs are going to take longer. Transfers are going to be harder. If we fall, we're more likely to go to the hospital. If we go to the hospital, we're really likely to have major setbacks. And then we talked about mortality. So for us, being care partners and family members and individuals with Parkinson's, there's a lot of things that we can do as far as interventions to help manage what we know is coming. We know the car is going to run out of gas, and we know it needs gas. So, we really want to put those interventions in place to stay on track. And that's the message that I give families. So again, I'll pass these trackers out. You have my permission to photocopy and use them. Use them daily if you like. However often you are going to journal, so you can see when you yourself run out of gas, because your schedule is going to be different than every single person in this room. Your body is going to be different. Your Parkinson's is different, depending on if you had a really busy day. You think about like when you're, you're just driving a nice, easy highway road trip, you probably get a lot more miles to the gallon, right? Versus if something's like stop, start, there's use more fuel. So if you have big and loud, or you've got LSVT, or you're at Madonna, or you went to a graduation, or whatever it was, you may have burned more fuel up that day. And so just kind of being more aware of your own schedule. Making sure you have a team. We've got a lot of really great resources in here. But if you have any questions about building a team, that's the main thing we want, is just for families to have connection to the resources that you need to understand, to be able to manage Parkinson's, and our goal is to help families stay home. So again, we provide Parkinson's education to understand symptoms, manage timed medications, help facilities, caregivers, care partners understand on and off times. We want to prevent a hospitalization. We want to prevent a fall and improve outcomes so we can continue living well. Thank you for having me today. I appreciate it. got an extra microphone. I'd be happy if anybody has questions, and then I may pass these around so you can take a look at these trackers.
Questions?
Thank you. Thank you. And then this is the master medication list. So they're two different things. Questions from anybody? Any aha moments for anybody? Wish they would have known?
So other than a life alert, what other techniques are there for letting someone know you fell?
Yeah, so I think everybody could hear the question, but the question was safety devices. So like I mentioned, for us, for our team, we have a 24/7 safety program. And so our families have 3 of these in their houses. One goes in the bedroom, one goes in the bathroom, and one goes in the living room. Well, where you spend most of your day. Most of the time it's living room. So that it's audio only, so that it can hear if there's only health and safety. That's all it can do. There's other families certainly that use technology such as like an Alexa or something, and she will be able to dial phone numbers. Ours doesn't require anything on your end, and it won't talk back. It will just alert us that one of our families, that there's a safety concern. So, yeah. And then there's certainly, you know, like when we have families, we help a lot of people with end of life as well. So there may be like bed alarms and that sort of thing if somebody has gotten up. You'll see that a lot in the hospital too. Yeah. Any other questions or comments? One back there, Joyce.
And the chart on the readmission rate.
Yes.
Comparison. Did they do a comparison study? Most people do not have Parkinson's.
Yeah, so Rich's question is for the statistic that was how many people were readmitted back to the hospital. He's asking if there was a control study of people that didn't have Parkinson's, right? Am I answering your question correctly? I don't know that. I know this study was just 500 people with Parkinson's, and really the intent of their study was to see what the consequences were of you not getting your medication on time. So that's why it was really only Parkinson's patients for that study. Yeah.
You mentioned that if you are having an especially busy day, that you might run out of gas more quickly.
Yeah.
So what can you do about that? I mean, other than just know that and be more careful. You can't take more of the medicine, right, to try to refill quicker.
Yeah, so the question is, when you run out of gas and you're not due for your next medication, what do you do? Because in general, we really try to stay on the same time schedule. I would talk to your prescribing provider about that. I don't know if anybody in here uses an Embracia inhaler. They have rescue inhalers. We've had, Joyce, I forget what the name of that company was, but we've had that company speak, but it was a Zoom, but there's a kind of like a rescue inhaler to get you by till your next dose. They're kind of reviewing that because when they look at studies as far as like the strength it takes to actually breathe in an inhaler and for that medicine to go where it needs to go, it's actually really difficult. But that's one you'll see on this like master list that is designed for that. But I would talk to your prescribing provider about what they recommend.
What happens if you take too much carbidopa?
Well, what you saw on this slide here, as far as this study of 500 people, share. I'll pull this up just to make sure I have the number correct, but I think it was like a 4% when it talked about length of stay. Yeah, that's okay. When we talked about length of stay, it was something like a 4% difference. So there isn't a very large consequence of overdosing carbidopa-levodopa. You may have an increase of adrenaline. For anybody in here that has a DBS, when you first got it and it was pretty high and they had to go and readjust it, Joyce, Rich, I don't know if anybody wants to speak to that, but you know, you kind of could maybe speak to what that feeling is like before they readjust it, so. Typically your provider, I know when I've asked Melinda, who was in one of these pictures with CHI, that question in person, she would just say to sleep it off. But you're gonna be on track, you just may kind of have an adrenaline rush, is what she told me, so. But to prevent that, you know, I should probably add a slide here with the an organizer. We really encourage all of our families to use a pill organizer because it is really easy to say, like, did I take my morning pills? I don't remember now. And then maybe you take them again. But if you can look at an organizer and you can see, oh, Sunday morning, well, it's gone. I must have taken them. So if you can have that visual, that will help reduce the chance that you overdose. But the consequences, as you saw in the study of 500 people, really the consequences of falls, rehospitalization, and death come when they're off track and we miss the medication. Any other questions? Comments? Yeah.
So could you go over again the absorption, how long we should wait before eating to take the medicine or after eating?
Yeah, I think the rule of thumb, as far as when the Parkinson's Foundation presents to us to do med reminders, is a half an hour. You could do longer if you want to, and I realize that sometimes we take meds, and there's people here in this room that take them every 2 hours. So then it's like really hard to figure out when to eat. But half an hour is a pretty good rule of thumb if you could try that. Wait 30 minutes, take your med, 30 minutes before you eat the meat, eat the protein part.
Yeah, but afterwards, you have to wait 1 to 2 hours, right? Before you.
Yeah, it really just depends on your med schedule. I know there's people in here that take meds every 2 hours. So I would talk to your prescribing provider about that. But what you don't want to do is take protein when you take your med, because your med will not work. It will fight with the protein and protein will win.
Any other questions?
Okay. Oh, someone.
Just to review that again, you're saying don't eat anything for 30 minutes before you take your medication.
I'm glad you asked that question. So it's not that you can't eat anything, because when we do take meds on an empty stomach, a lot of times we'll get nauseous. Fruit, crackers, bread, whatever you want, it's just the protein. So like if there's a meat, or you know, like I showed you that picture of that Ensure, there was a high protein Ensure. So it's just holding the protein, on average, half an hour. Just wait to eat the protein part. You can't eat, just wait on the protein.
Right. And that's pretty difficult because so much has protein in it.
Yeah.
So then you're saying, I personally was told I should not have any protein for 2 hours before I take my medication.
I would say if he's saying his doctor, neurologist, movement specialist, whoever this is, told him 2 hours, do whatever your doctor told you. Yeah, they're the doctor. I would just go with that direction. But in general, like I said, when I'm presenting to facilities, they're not aware that there is any issue. And so at least at a minimum, I let them know they need to wait 30 minutes. But if that's what your doctor says, just make sure you write that down. And if you do happen to go somewhere, like have to go to the hospital, let them know that is what your doctor told you.
Okay.
So they follow suit.
So the other thing is, they've also told me not to eat anything for an hour after I take the meds. So there's 2 hours before the medication is taken that you can't have anything. And then there's another hour after you take the medication that you can't have anything. So Yeah, we're talking protein, no protein, which is just about everything. So you're talking 2 hours before and an hour afterwards, that's 3 hours of not eating. That doesn't go well with me. So, that's my concern.
I understand that, yeah, so I would talk to your prescribing provider, what the alternative is. And again, it's not that you can't eat anything, it's the protein. So there may be part of the meal, it may be like you can have your fruit and salad, but you need to wait for the chicken, however you look at that. Yeah, I don't want anybody starving, I can be getting hangry just thinking about that.
I would check with that doctor pretty quick.
Yeah, just kind of verify that with your doctor, yeah. Okay, great. Well, we're going to, this is where I want to separate and put,
I've got a couple of.
is the kitchen open today?
I've got a couple of.
No.
Thank you, thank you. You're welcome. Well, no, that's when she came and we've been blessed with that. On your table, I didn't put one for everyone because we've handed out this letter previously. But it talks about some of the needs that we have for our support group. For instance, today's a perfect day to mention this. Our secretary couldn't be here. And so it would have been nice if she had had a backup person to do the table, hand out the name tags and do all that, take new people's names and get their address. So that's the type of thing that we're looking for. So if you read the letter and you see something on there that you might be able to personally help with, we would appreciate it if you could contact me or Sally. I think the email addresses are on that letter, so we appreciate that. The other thing, Jim's not here today. He usually brings the library. We have to have the library. But I did bring a couple of sets of Every Victory Count books. They're very useful. There's one for just general information if you have a question, and there's one for caregivers. So if you would like one, one's gone. Two's gone, but I do have more at home, and I would be more than happy to get them to you at a time that when I have a meeting, I can do it. So there's lots of information. The other thing I wanted to bring up, Carla's presentation was kind of a follow-up.
Yeah.
For our last month's meeting, Parkinson's Foundation, and we're talking about hospitalization today. And this is great, hospital study guide, and it's from Parkinson's Foundation. And if you contact them, they will send you this free of charge. And I really like that booklet. The other one is for care partners. Plus they have a lot of other information. If you go to their website, you can look through that, and whatever you feel will be helpful to you, you can call them and they'll send it. So just to try to remember that. I would be asking about the protein from the foundation, just to get information too. The other thing I got in the mail was I'm a big advocate of, I think our pesticides are killing us personally. And Ray Dorsey is a doctor from New York, and he's worked with a Dr. Okun from Florida, and I can't remember the doctor's name that's from overseas, but they have written books about the risk. But this is what I got this week. Proximity of golf courses and risk of Parkinson's disease. And there's 126% higher risk of Parkinson's for people living within 1 mile of a golf course.
Chemicals they
Those with tap water drawn from groundwater near golf courses have nearly doubled the risk. The risk increased by 82% in areas with vulnerable groundwater systems. So I had to remember that one of the nurse practitioners that we saw for Parkinson's does live on a golf course. And there are things that you can do, or if you have friends that live on a golf course, you may want to warn them. But it's not just golf courses. I grew up in an area where they crop dusted, and we have we had a well. So I'm sure I drank a lot of that yellow powder that was on our back porch. You can ask the golf course to reduce its pesticide by 50% or use organic. Ensure the groundkeepers have proper wear, boots, gloves, whatever they need to protect themselves. Talk to your local officials, support bans on pesticides. The countries that have banned paraquat have reduced their Parkinson's number. And I believe it's still legal in our country. And then they mentioned buffer zones. If you're in a situation like he talked about, it's homes, schools, parks, those places. Walking over the park the other day with a granddaughter, and I wondered, I guess now I'm paranoid, but as I walked through there with my sandals on, I wondered what I was taking through my feet. Anyway, it's not only Parkinson's. We have a lot of kids. The percentages of kids who have not only different diseases is high. So I think we really need to let our voices be heard to stop some of this pesticide stuff. So anyone else have a comment about anything they've learned or would like to share? Next meeting, we're going to have Michelle Spiker. Did I say that right? Spiker. Thank you. Sally always has to correct me. I can't seem to remember her name. She's going to talk about incontinence. And so that will be June 22nd next year. Again, Gunter, thanks for setting up the Zoom. Thank the people on the Zoom. Thank all of you for coming. Do we have any newcomers today?
My name is Holly Johnson, and this is my husband, Donald.
Gee, I don't have to say a word.
Any others? Oh, good.
Karen Buckley with Dennis Buckley.
We won't. What we do at this part of the meeting is divide into two groups. Those with Parkinson's will stay in this room. The caregivers will go to the kitchen. We'd like to thank Sally for setting up coffee and water and like some delicious cookies over here. So we'll break now, and yes, Sally.
Ice cream social next month.
Ice cream social next month. Yay. So we can do that right now and in about 4 o'clock.